I'd like to invite Dr. Rupashree Dasgupta. She's a very senior gynecologist, gynae-onco-surgeon at Apollo in Kolkata. And she will be telling us as to which patients are likely to benefit from the robotic surgical technology. So, Dr. Rupashree Dasgupta, please, over to you.
Good morning to everybody, and let's move on from Dr. Anshumala and talk about the clinical indications. So when we talk about the advantages of the agenda for today's talk would be, first I'll talk about the advantages of robotic. What are the indications with evidence in both benign and onco, with a bit of clinical scenarios and videos if possible, if we have time, and a few take-home messages. When we look at surgical approaches in gynecology, there are many of these approaches which are available, and robotic is one such approach. And today we will discuss what are the indications and what are its advantages compared to basically laparoscopy and open. Now it's a breakthrough technology. This is not going to, it's not a replacement for laparoscopy. It aims to overcome the shortcomings by overcoming the surgeon shortcomings and the equipment limitation. And the end result, we end up with less morbidity, faster recovery, and greater surgical precision. This was a study done by our president, Dr. Uma Sinha et al. And it shows that how the uptake of robotic has changed over the scenario over the last 10 years, and more cases is being performed on different kind of platforms. Today again I'm going to speak on the Da Vinci Xi because that is what I work on. And as every study later on you will see that say that the robotic OT console time is longer than lap. But if you look at this study, if you see that the number of years and with the experience of the performer or the surgeon, the console time will gradually come down. Now this is just an overview of the robotic in our hospital. It's an Xi, it's a Da Vinci. You have the boom. The reason I'm showing this is because when we do a multi-quadrant surgery and we're looking upwards, the boom just rotates around, and then it becomes very easy for us to actually perform both the surgeries without having to dock and redock 10 times. These are the small movements that you make with the hand, and now it gives us an immersive view through a 3D high definition visualization. You feel as if you're inside the abdomen when you're operating. The camera is under the surgeon's control, and so minimal use of the assistance, and it's a very steady camera. You can move it wherever you want to. Wristed instruments, improved ergonomics, and that helps us with better suturing and dissection in confined spaces. Now, when I was talking about the wristed movement, this is the endo-wrist movement, which I've tried to make this video to show the beginners who are looking watching today to see that how the movements of the robot or the wristed endo wrist, it actually follows the way that we do open surgery with a 360 degree rotation. Now, the other advantage of the robotic is we have something called the Firefly technology, wherein when you inject ICG dye to inside the ureter, or you want to look at endometriotic lesions, ovarian cancer spread, sentinel nodes, isthmosil repair, anything, you inject the dye, and this camera emits a near infrared light which picks up, and this glows green, and that helps us in preserving many organ functions. Now, this is another chart which shows the comparison between open laparoscopy and robotic. Recovery is very swift. Laparoscopy and robotic, there is not much difference, but as I take you through the indications, we will see what are the advantages. Now, port placement, as I said, in benign cases, you don't have to go for a straight line. In some cases, when you're doing the upper abdomen and you're doing a multi-quadrant surgery, this is generally how I put the port. That time I go straight because I need to work both downwards and upwards. You just turn the boom around, and the camera port is the extra port that we take. The rest port remains the same. Now, these are the post marking. That is the area of no entry, and we should not put any instruments down below. This is how it looks when I use the third arm. I generally take the assistant on the opposite side, so we have assistance from both directions. I don't know, for some reason I started with right side docking, and that is how comfortable I am with that. Now, in a benign gynecology, let's take benign first and then we go with onco. Now, we do a hysterectomy for benign disease. Robotics can be done for every single case, and I feel that it gives us a better control over the surgery in every single case, but it is especially useful in large fibroid uterus where the anatomy is distorted with a broad ligament or a cervical fibroid, in severe endometriosis, dense pelvic adhesions, obesity, high BMI, narrow pelvis, and complex pelvic reconstructive procedures. Now, if you look at the evidence, then Dr. Edwin Kula et al. Has done this study, and which has compared the laparoscopy laparoscopy and robotic surgeries, conversion to laparotomy is significantly lower with the robotic in case of difficult cases, and there is no difference in complication rates in both the procedures. Now, what happens in a difficult large uterus? You cannot see the pelvis properly, but the manipulation of the large uterus is made easy by using the robotic platform. We are going to go very fast with all the videos here, and the dissection is much easier for the bladder even when you have any previous surgeries, so injury chance is less. Better visualization with the 3D magnification, easier to safeguard the ureter. So when you open the lateral peritoneum, it's very easy to open the lateral peritoneum on the robotic platform. You can see that this is the ureter here with the arrow here with my marking, and then you can clamp and cut the IP ligament. Next, when you are having a better uterine artery control, you can see that this is the ureter coursing at the side, and we are well away from the ureter. So this is an advantage. Another advantage here, when you see with a broad ligament fibroid, we know we are worried about the ureter on the lateral side. And so here in this case, we can use the ICG dye because the MRI had said that it was sitting right on the ureter right there. So you remove the fibroid first from the ureter and keep dissecting. And finally, you can see that you've pushed it well away and you've protected the ureter. Yeah, you can see the glow there. Now, coming to myomectomy. In myomectomy, what are the advantages that we have on the robotic platform? And just a second, I just missed out my screen. Yeah. So when we have multiple fibroids, deep fibroids, when we are doing a fertility preserving surgery, which requires multi-layer suturing, and we have abnormally located fibroids, and even in adenomyomectomy, robotic gives us a better control and helps us to, why is my screen not moving now? Sorry, my screen is not moving. Just a second. Am I audible? Am I audible?
Yes, you are audible.
Yes, you're
Dr.
audible.
Rupashree. Yeah.
Yeah, so now if you look at the evidence for myomectomy using the robotic pathway, so this was a systematic review and a meta-analysis which shows that apart from the operative time, the blood transfusion, the hospital stay, the intra blood loss is all better with the robotic platform. The conversion to open is also lesser on the robotic platform. Post-op complications are again lesser. This is another very interesting study wherein they have compared the laparoscopic myomectomy to conventional myomectomy in cases where we are trying to preserve the uterus for future fertility, and they saw that doing an ultrasound at 1, 3, and 6 months, the hematoma chances are much lesser in a robotic. It means that the healing is better when the patient is trying to conceive. This is another study by Dr. Uma Sinha et al., wherein they have done an extensive 10-year observational study which shows that there is a very good healing rate and pregnancy rate after robotic myomectomy, which is 86.4%, and they never had a uterine rupture in the 10 years. Now, this is one of the difficult myomectomies that we have done in our surgeries in our hospital, where you can see that this is a large cervical fibroid. And first, initially, we would think that it is quite difficult to attempt this on the laparoscopic platform, but in the robotic platform, you can see that this is like a lantern sitting on the cervical fibroid, the dome on St. Paul's Cathedral. And when we assess it adequately, we have already stented the ureter in this case initially. So we open the UV fold first. Robotic helps us to go deep down into the pelvis and further dissection to remove the bladder downwards, prevents bladder injury. Lateral side, we are opening here till we find the IP ligament. I'm still searching for the ureter. Here I find the ureter coursing right through the fibroid. Now we've identified the uterine vessels, coagulated and clamped them. And then further dissection is done to remove this giant fibroid, and it's a successful surgery. We've preserved the cervix, the uterus, and we've managed to remove it. Now, another important advantage of is the multi-layer suturing, which is easily done on a robotic platform. This is a submucous fibroid, but a patient had completed her family. She had such a large submucous fibroid that it was difficult for us to remove it hysteroscopically. I had given her GnRH. Even after 3 months, it was refusing to shrink. But on the robotic platform, we were able to do this with ease. And following that, the multi-layer suturing, which is done here, where we have not included the endometrium goes in, and it is done with ease on the robotic platform. It's quite precise, very neat, hardly any blood loss. This is the first layer. Now this is the second layer. I'll just take through very fast because of the time, and this is the third layer. So going from myomectomy, we will now go to endometriosis. I think the robot was built for this kind of surgery, whether it is endometriotic cystectomy or a DIE or a bowel disease, ureteric endometriosis, bladder endometriosis, complex adhesiolysis, or we are doing a fertility sparing endometriotic cyst surgery. Evidence shows that a robotic surgery facilitates meticulous dissection in distorted anatomy and helps in organ preservation. Let's go with the ovarian cystectomy, where we need a fertility preservation. What is the advantage and the indication? So this study has shown that when you compare robotic with laparoscopic surgery, the percentage of AMH detection after robotic surgery is much lesser than that of a laparoscopic surgery, with a significant p-value. This is our own Ruma ma'am study, where she has also demonstrated that when you are doing a robotic surgery, actually we are not yanking on the pedicle, we are not yanking on the cyst, we are actually doing a micro dissection. And after that, when the cyst was compared using artificial intelligence whole slide imaging, they found that the area of ovarian loss was much higher in a laparoscopy rather than in a endometriotic surgery. We are not pulling, we are just doing micro dissection, and we are just dissecting and preserving the ovarian function. Now, when we go to a difficult surgery, like an ureteric endometriosis, where there is so much of adhesions, in this case, you see that the anatomy is distorted, the ureter is completely adherent to the parametrial nodule there, endometriotic nodule. So here we can again do the micro dissection. It's preventing the ureteric injury also because of precise ureterolysis. In difficult cases where you need nerve preservation, you can identify the nerves and preserve them also. And once the ureter is dissected off, we go in for the butterfly peritoneotomy. You can use the ICG dye here. We have used it in the intravascular injection to see the vascularity to the ureter is preserved or not. And then we complete the rest of the butterfly peritoneotomy and shaving off from the endometrium. So this is the way in which we use it in endometriosis. You can use ICG dye also to pick up the endometriotic lesions and also to see if the bowel anastomosis is proper or not. So the entire butterfly peritoneotomy is done. This is how it looks at the end. Now, this is another good video wherein you see that when we are not able to approach a very difficult vaginal nodule there, a laparoscopy instrument may not be able to reach that deep, and your assistance also would be difficult for her to reach that deep to assist you. Robotic will give you that platform to reach there down very easily and help to remove that nodule. Coming to the next indication in benign gynae, that is pelvic organ prolapse, sacrocolpopexy and pectopexy. What does the evidence tell us? There are two meta-analyses here I'm giving you side by side. Jiang et al., they included 3,000 patients and showed that there was a similar anatomical and functional correction rates between robotic and laparoscopy, but always the conversion to from lap to open was higher than the conversion from robotic to open. So, and also in this other study, they showed that it is very much useful in complex. It's a meta-analysis, and the meta-analysis, if you look down below, that you see that the functionality is the same, but it is much more useful in complex or technically demanding cases, especially cases where you need to do a resurgery or a redo prolapse surgery, or in complex cases where there is a lot of adhesions. So here again, because of the robotic instruments and superior dexterity, you are able to get a good vaginal cuff. You should be able to dissect the bladder completely off with a long length if you have a cystocele actually, and posteriorly also we need to dissect based on how deep is the defect. If there is a rectocele, then we need to go right up to the levator ani and the perineal body. Now coming upwards, here we are opening. Here you can see that how the robotic one arm is helping to keep the bowel away, and you are dissecting with ease to open up the tunnel and the sacral promontory. There is hardly any blood loss, and these surgeries are done with ease. So once you have created the tunnel, now you've taken the mesh and the mesh suturing is especially easy in these kind of cases. Here I've taken a macroporous polypropylene mesh, and I use non-absorbable V-lock sutures. You can use interrupted or continuous. Look at the posterior suturing made easy here. This is what I wanted to demonstrate. And once the MEX fixation is done, it is fixed actually very stably in a robotic platform. And then after that, you can take the Y and then look at the suture here. This suturing is also made very easy on the robotic platform with this Proline, where I take 2 or 3 bites on the sacral promontory. It's so easy to dissect and stay away from the ureter on the right side and the median sacral artery on the left. Once you take these knots, and it's easy to just take this thread through the wire, and very stable and full control. So these surgeries are done very much easily on the robotic platform. Once the whole thing is over, you reperitonealize the tissue. And when cost is a factor, so in benign gynae, when cost is a factor, we don't need to use the third arm always. We can use the needle driver to do lots of your dissection. In this case, it is dissecting on the left side. On the right side, you will see it's a large uterus, and the arm itself is helping us to give the traction and lift up the pedicles.
Dr. Rupashree, 2 minutes, please.
Yes. Okay. So role of robotics in onco. If you look at CA endometrium, CA cervix, and CA ovary, strongest evidence is for hysterectomy, central lymph nodes, pelvic and parotid nodal assessment, and omentectomy for high-grade histology. In cancer cervix, we know after the LAC trial, we are not doing a lot of robotic. We are waiting for the RAC trial. And we recently saw that the analysis of the RAC trial in the surgeons meeting, that the sentinel node uptake is very high in a robotic platform. Robotic still has a role in fertility-sparing surgery in radical trachelectomy. In CA ovary, the role is limited, but we can do it in early stage cancers, in interval debulking surgery after the MIRRORS trial, and secondary cytoreduction in selected cases where there is not much disease left in the pelvis or the abdomen. Now, this is a very important study which shows that in CA endometrium, we know that the patients some are obese and morbidly obese, and this analysis shows that especially in cases of BMI more than 30 and 40, the conversion rate is much lesser in robotic, and also it is gives a greater benefit in technically challenging patients where we have to give a Trendelenburg or the exposure. In these cases is where the robotic comes into play. Now, in this meta-analysis also, it shows that when they compared robotic to laparoscopic in endometrial cancer, the conversion to open was much lesser, but in robotic platform, but there was no difference in overall survival or disease-free survival. Now, in vulva, we use it for doing the veil surgery for very early cancer when the tumor is less than 4 centimeter, and the groin study has shown that there is a decreased wound background infection and lymphocytes with that. And in radical other pelvic surgeries, we use it for pelvic exentration. It is increasingly being explored, but we still need to have better studies to demonstrate that. This is just a small demonstration of how we are using the Orogreen. We are first injecting it superficially and deep after diluting the ICG dye. This is the port placement, and then once we are inside, you see which is the sentinel node. You take care of where the sentinel node is. Have a look where it is. By putting on the Firefly technology, it will pick up the color, and then we can actually remove the node. So because we're running short of time, I don't have much time to show you this. So this is how we do a sentinel node. This is how we do an bag. We put the whole thing in early ovarian cancer. When we are worried about spillage and oncological outcomes, we never aspirate the cyst. We remove the cyst intact, put it in the bag, close the bag, and take it out from below. This is another case wherein we are doing an omentectomy, where it really helps. It is a game changer in omentectomy because the exposure is so important. The way that you dissect is so important. You're going to work in narrow spaces near the spleen. You can come in with the vessel sealer, and the robotic helps us to complete the surgery in a quicker and faster fashion. So the vessel sealer again helps in reducing blood loss. When you go to the pelvic nodes, again, it helps in meticulous dissection. And in the parotid lymphadomy also, the robotic gives us a good platform for us to actually dissect all the nodes faster and complete clearance. There are few studies which have shown that the nodal yield is higher on a robotic platform than on a laparoscopy platform, but they are not very statistically significant. So we can reach right up to the renal vein here. That's the renal vein over here. And you can do this dissection very clearly. So this is the evidence summary, wherein if you see that there is a very strong indication level 1 evidence for endometrial cancer, benign hysterectomy, all is level 2. We need much more larger studies. So the conclusion would be that in a surgery, always think one step ahead. We have to place the instruments in a robotic surgery. Stably, we have to put the exposure before dissection. Economy of movement, very important, and the coordinated movement ends in surgical choreography. Now coming back first to my first slide again, that when a patient comes to us with so much of hope, we are thinking about the success rate, what is the good chance that we can give. We have to tailor the surgery according to the patient's desires and our surgical expertise, and for that particular situation, which is important, and we have to take all these things and not only jump that we will do robotic for her or laparoscopy for her. Discuss it, take an informed shared decision making, and then decide which is the best for the patient. And we are all members of AGRS. Ma'am is our president. This is the website. Please click onto this website, agrs-india.com, and it will take you straight to the membership portal. You can take a 1-year or 5-year membership if you are don't have a robotic certificate yet, but if you are certified, you can become a life member. Thank you, one and all.